Apa kabar Mas Gus? Sehat Mas Gus?
Lagi jaga, baru lepas jaga nih, setengah jam lagi.
Oh, setengah 8 Mas ya? Bukan jam 8.
Selamat pagi,
Ya,
Mas Fitra, Mr. Chris.
itu setengah delapan.
Pagi Gam, mau marin rindu kali sama kamu Gam. Apa kabar Gam?
Iya, saya juga, Mas.
Ayolah.
Saya kita ketemuan nanti, Mas.
Kapan?
Kapan aja dah.
Dokter Dokter Iwan ke Vietnam Gam.
Iya, tapi ke Ho Chi Minh.
Apa?
Dokter Iwan Mas ke Vietnam.
Dokter Gema,
Ya, siap, Dok.
ini ya yang pada ke Vietnam dokter.
Dokter Abrar pergi Mas enggak ya?
Dokter Abdar ada di sini.
Oh, ada. Mas, ini ya Mas ya. Sekarang respon arahnya udah ke Cavernoma Brainstem, udah ke CA. Saya
Iya,
pasien
lagi
TI.
banyak.
Pasien TIA saya CT angiografi sampai ke arkus aorta nggak ada yang ketemu mas, aman-aman semua. Yang TIA semua saya CT angiografi mas, nggak ada yang ketemu.
Belum.
Belum.
Good morning.
Good afternoon, Mohammed.
Hi, it's
Oh,
Amrin. Hi, it's good to see you.
You were really nervous because you thought that I was not gonna make it, right?
No, it's always happened in a webinar between countries
Yeah,
because I'm always afraid I tell the wrong time because the time differences.
yeah, I
So
know.
I always nervous at the end. Like, did I tell him the wrong time? So I asked Hafif to call you, and then he told me he didn't answer, and was like, "Oh shit."
No worry. It's okay. I'm right here. Sorry about that. I was just running
No, no,
because I
no.
had to rent a tuxedo for tomorrow. I have a wedding. So
Whose wedding?
one of my friends of the residency is
I
getting
thought
married.
I thought it was your wedding, and I was like, "How dare you didn't invite me?"
I know. Dude, remember I'm only married to vascular neurosurgery and bypass. Just I will be here, just give me 1 sec.
Okay.
Yeah. Okay, ready, mate.
Yeah. So we're gonna start in 5 minutes. If you have some video, I think it's a good time. You can check. You can run your slide.
Okay, I have here the slides. Just let me. Do I share it so we can see if it runs or
Yes.
okay.
So while you're preparing your slide, oh, nice. I can see it.
Yeah,
It's not
let
in
me
full screen.
see. Is it running?
It's running well, but it's not
Yes,
in full screen yet.
it's not in what?
It's not in full screen.
Yeah. I just open it like that, but let me check it in like this.
Okay, nice.
Yeah,
Perfect. Yes. Very good.
there's a little bastard. The IMAX.
Oh man.
I really hope you enjoyed the lecture. I mean, I tried to do it like what is bypass, atherosclerosis, talk about a little bit of the fluid dynamics using Charvel. I mean, I really hope that Tanikawa Sensei is not online because if he sees that I'm talking about
The Charwell.
yeah Charvel and fluid dynamics, he will be really mad at me.
Yeah. Yeah, I mean, this is something very, very new to our community. So, like, everyone is excited. And while waiting, I will introduce you to some of our faculty. We have some
Yeah,
of them. No, it's early Saturday morning, so uh,
yeah. Here's the afternoon. Yeah, thanks for
Saturday
hosting me
morning,
at this time.
snow in Jakarta, but some of them already here. We have Dr. Fitra from Banda Aceh is
Hello, Doc.
uh,
Hi, nice to meet you.
Nice to meet you,
the
Doc.
corner of Indonesia, Banda Aceh, and he's one of a very good vascular neurosurgeon in our country. Have Dr. Dr. Ferdinand Chungkagi is from Manado. So
Hello,
it's
Dr. Javier. Nice to
Mm,
meet you.
nice to
we,
meet you,
we,
Dr.
we are a
Ferdinand.
really small community. We are only 500 people, and we only have 20 to 30 vascular neurosurgeons. So very small number. It's like a group of people fighting together. So we are very close friends. We have Dr. Gema here. He's from the island of Bali. You know Bali, right?
Yeah,
He's from the island of Bali. So can you imagine working in Bali?
yeah.
And we have Dr. Krishna just join us. I think he's joining us from Italy because he's attending a skull-based course. He's invited speaker for skull-based course in Italy. Dr. Krishna, thank you for joining us. I don't know what time
Halo,
is it.
halo Dr. Kustiansa. Sorry for coming late.
I don't know. We haven't started, so uh, one more minute. What time is it in Italy, Dr. Krishna?
Now it's 2 in the morning.
Oh no,
Two in the morning.
Yeah.
Wow.
sorry to disturb you
No, it's
after
okay.
hour.
It's okay. I still have my Indonesian biological time, so I wake up this time also.
So we have some panelists also will be joining from another countries. The time difference is crazy, but we have the same spirit of learning vascular neurosurgery, which is very exciting. Yeah. Okay, so let me check if there's the other panelists will join soon. So maybe I will start with introducing you, Javier.
Yeah, it's okay.
You have a very long CV, so I'm trying my best to shorten
No,
it
it's
up.
okay. Don't worry.
So good morning, all participants. We have currently 55 people joining in, and it's still increasing. And the panelists as well. Thank you for all the panelists, both local and international panelists that have joined us. I'm glad to have this interesting session this morning, and we have a very special guest, Dr. Javier Regulado Garcia. I'm sorry if I pronounce it bad. he's, he's a very good friend of mine from Mexico, and very passionate about vascular neurosurgery, and I've been inspired by him since we met in Sapporo last year. And you know, our I always say our kind of people that love neurosurgery, drink, eat, and married with neurosurgery, you say vascular neurosurgery. So it's very interesting to meet people from different countries, different cultures, but share the same passion in neurosurgery. Currently, is working in the Mexican Institute of Social Security, and his specialty is vascular neurosurgery and cerebrovascular and skull-base surgery, especially in vascular reconstruction and bypass. And for graduating neurosurgery, he spent a lot of time sharpening his skill in vascular neurosurgery. He spent his fellowship in Manuel Velasco Suarez in Mexico, and then he spent another fellowship in Sapporo Tesinkai, where we met and learned together about bypass. And he also attended a fellowship of skull-base under Dr. Ali Chris and clinical observership in Illinois, USA, under Dr. Fadi Charbel. So he's really spent his time traveling around the world, learning from the masters. And I thank you very, very much to squeeze your time between your activity to share your expertise and knowledge. And I hope we can all learn something very interesting today and have a nice discussion. So yeah, there's still more, but I cannot read all of it. But yeah, basically you're the master in skull-base and cerebrovascular surgery. So before starting this session, some rules has to be applied. First, for the panelists, please mute your microphone, and if you want to ask, please raise your hand during the session. And for the attendees, it's just the chat box and Q&A box to ask question, and then I will read the question if time permitted. And this session is recorded, so if you prefer not to be on the video, you can turn off your camera, and then please be respectful and courteous to all participants. So please, how should I address you? Professor De Gulano. Please start, please share yours.
Okay, so you want me to start now?
Yes.
Yes.
Please.
Okay. Do you see my slides?
Not yet.
Not yet. Just let me check. Do you see it now?
Yeah, perfect.
Perfect. Okay. First of all, I want to thank Mohammed and everybody to just let me share this Congress with you guys, and I'm really glad to be here with you guys. So thank you so much for giving me this opportunity. As he introduced me, my name is Dr. Javier. I'm from Mexico City. And well, I'm passionate about bypass surgery, and I choose this topic because I think one of the important things about being a vascular neurosurgeon is to push the boundaries. So I think this topic will enlighten you in ways that how can we do that in a topic that it's many times just left behind to the neurologist or to the best medical treatment. Okay, so I'm going to start. Well, first of all, what is the cerebral revascularization? Okay, so it's a procedure that allowed us to preserve or restore the blood flow, redirecting the flow from another artery. So having this in mind, there are only two ways to do that: direct or indirect. So many of us know about moya disease and everything, so we are well familiar with both of these techniques. So in this lecture, I will concentrate only on the direct revascularization. So what are the indications for doing this procedure? There are only actually two indications: replacement or preservation of flow, and flow augmentation. So those are the only two um, indications that we have to do this kind of surgery. So if we are going to do replacement or preservation, is most of times for complex aneurysm, giant aneurysms, or vascular lesions. And flow augmentation is vascular lesions, stroke disease, moya disease, moya syndrome, and moya angiopathy, all the three of them. And in this case, atherosclerosis or stenosis, that is the topic that we are going to talk about. Okay, so atherosclerosis. Revascularization in these patients only makes sense when the patient have a hemodynamic failure. So how do we know which patients have this hemodynamic failure? Okay, only 10% of the patients with atherosclerosis have this kind of presentation. Okay, but what's the problem and why it's important to know this? A patient with atherosclerosis goes to a state of chronic hypoperfusion. And what this means to the brain's patient is that the excitability and the brain function is going to decrease. And they will start presenting something that is called hibernating brain. In the Berlin vascular meeting in Charité under Professor Barkowski, they describe this. And what is this? As we can see in the images, like all the motor cortex is start to turn off. And that's the problem. The motor cortex starts to turn off, and that means that there are less neurons that will activate movement in this patient. But what's the important thing? If we can change this, as we can see in the second image, that part of the brain gets glowing again. This meaning it gets perfused and it recovers function. What's the other thing that they're doing in China? They're seeing cases that patients that with vascular dementia of chronic hypoperfusion, they can be reverse this pathology if they have a well-studied case and a well-reperfusion. And that's important thing that we're going to see this. In these patients, all these symptoms are reversible with bypass. Okay, so what are the stages of a patient goes when it has an hemodynamic impairment? There are three stages that are described. Stage one is when the patient is not receiving enough flow. So what the brain do, or well, the arteries, they start vasodilating. So when they do this, it's only to increase the flow so it can get more flow to the brain. Stage two is the misery perfusion stage. It is when the vessel is at its maximum vasodilation. So what the neuron and the brain start doing, they increase the oxygen extract from the blood so they can keep all the functions of the brain. And then we have stage three. The stage three metabolism is the true ischemia. And we have like different degrees of ischemia. We have from true ischemia, that is stroke, we have penumbra, and we have oligoemia. So we're going to see what are the difference between of them. So, but the patients that are at higher risk of stroke are these ones, the ones that both lost cerebral and metabolic perfusion and function through the impairment of blood flow. So, okay, how do we study and how can we do this diagnosis? We have different kinds of studies. The first one is a normal CT with an angio. So in this case, we can see if the patient have plaque or any calcification in the arteries through the MRI, we can see the composition of the plaque. Why is it important? Because we can see if that plaque is an unstable plaque, if it got more fat, more calcium, or anything, so we can know with what are we dealing. And the DSA-4 only help us to know the grade of stenosis. Okay, what are other studies that we can use? MRI NOVA. The important thing about the NOVA is that we can know the actual preoperative flow through the arteries. And it's important to do it with a vasodilation test. Most countries have what is Diamox. Here in Mexico, we don't have Diamox, so we use a different kind of protocol. We use the vasodilation with CO2. What we do is just make the patient inhale its own CO2, and after that, wait like about a minute. That is what it's described. And after that, the patient will do a vasodilation almost as if had a Diamox dose. And after that, we can do also perfusion test. The perfusion test is the key study of all of this. So we can have it by different kind of ways, with a PET, with a SPECT, with an MRI. Which one of these ones are the best? The best is the PET. The higher sensitivity of all that is with radioactive water. So that's the best study that we can have, but it also is the one that is more expensive. So most of the times we use only MRI. And as I show you in here, the important thing is that with the vasodilation test with Diamox or CO2, the important thing is the perfusion has to increase about 10 to 20 millimeters of blood flow. So that's what we are seeing in these patients. And why is important this? Because now we can know what's the actual state of the patient. And also we can, or we should, study it's called vasoreactivity. What is this? It's how the vessels will act with the CO2 or in a vasodilation test. So what we do is do the apnea test. So we can see the percentage that will change in the velocity of the MCA during hyponormal and hypercapnia. The important thing here, as you can see in the charts, is how after the apnea test, the flow increases. So that's what it's normal. So the patient that it's not capable of doing that or does it in a less than 35%, the patient is no longer able to have more vasodilation. So a patient with an altered transcranial Doppler, we can conclude that at least is in a stage 2 of hypoperfusion. So there have been a lot of studies starting from the external internal cranial bypass surgery, the indications of the cause study and everything. And recently it was published like 2 months ago, the CMOS. Okay, all these studies tell us that there's no room for bypass in atherosclerosis, that all patients have the same morbidity, even they have more risk of stroke and everything. But as I told you, this lecture is to push the boundaries. So despite of all of these studies, there have been a lot also studies that they say the contrary of this. We have from Dr. Peter Bakowski, we have from Dr. Morkos, we have from Professor Charbel, we have from Professor Mustafa Baskaya, Michael Lawton, Shubin. All of these are papers that they say how actually well-selected patients, they will get a benefit of our cerebral revascularization. So what are the indications for bypass in atherosclerosis? So is patient that has obviously atherosclerosis, multiple vessel atherosclerosis, recurrent ITAs or crescendo TIAs, or amaurosis fugax, and an altered perfusion, as I told you. Okay, what are the physics fundamentals about this? All of bypass surgery is based on Hagen-Possible law. So we can know the actual flow that it's going to go through the arteries and everything. We have to make measurements about everything. But the important thing, a lot of the years and through the time, was giving special attention to the radius of the anastomosis, because we can see that it's the most important factor through this, but that's when you see it like only in the theoretical plane. When you pass this equation to the in vivo or inpatient actual state, the important thing is the delta P, the delta pressure, the difference of pressure between vessel A and vessel B. And I'm going to show you an example of this. So having this in mind, we have a patient that has a fusiform aneurysm in M1 segment. We can use the flow probe, as we can see here. The dorsal and the ventral branches of the MCA, one has 35 and the other have 30 millimeters per minute. We have an STA that when it's open to and cut, we have 60 millimeters. So perfect. We do a regular bypass, end-to-side bypass, and we measure the flow running through the STA, and we can see that the flow is only 10 millimeters. Why? Because we are not creating the demand. We are not creating the difference of pressure. That is an important thing that also Tanikawa sensei does, goes and measure the pressure gradient. And in that patient, when we do the trapping of the aneurysm, that bypass is the same anastomosis, is the same vessel, is the same everything, and the flow goes six times higher. It goes from 10 millimeters to 65 millimeters. So what's the important thing here? To create the demand. It's not about the diameter. If we do all the calculations and we do a correct bypass with the correct diameter and everything, the important thing, or the most important thing in vivo, in the surgery, in the patient, is the gradient of pressure. So that's why Professor Shubin published this study, where he was like measuring the pressure with an intravessel manometer that we can see in here after the STA was anastomosed, and he measured the pre and post pressure. And we can see that the pressure from the donor arm to the recipient changed, and it was almost the same. So the gradient pressure was equalized in this way. So that's what we need to do to create the demand in these kind of patients. The important thing in patients that have atherosclerosis is that they already have a low pressure in the arteries because they have low flow in this. So it's a whole system that is low on pressure, low on flow. So when we add kind of flow, the gradient is already formed. It's a natural way that bypass is going to work. So how do I like to study and analyze these kind of cases? So I do it through these 5 steps rule. Like, first of all, what's the indication? So as we saw, there are only 2 indications. Point number 2, how much flow do I need? How do I know this? With the pre-op studies, with NOVA. And if you don't have NOVA, we can use the perfusion test. So do I need to revascularize the whole hemisphere, just the MCA territory, the ACA territory? Which part is the more symptomatic for the patient? That's another important thing that we have to consider. In all these patients, in atherosclerosis at least, the principal symptom is motor symptoms. So the location that we have to prefer, or we have to direct that flow, is to the motor cortex. So after knowing all of this, the point number 3 is we have to answer these questions. Which is my donor? Which will be my recipient? How is my reserve? And how is my flow? All these studies and all these questions, with the test that I show you, you can answer this. And after that, do I need a graph to do this? And after knowing all of this, we start actually with the bypass planning. That is, which anastomosis is the best possible one? And after doing that anastomosis, how do I verify that that anastomosis is working? And not it's only working to the trans-op and through the ICG and all the tests that we can do. The most important thing is, how do I know that that anastomosis would last through the time? And after knowing all this is which approach do I need to do that can meet all these criteria. So after this is like Tanikawa sensei told us, the total flow of a vessel that we were going to revascularize, it's formed by the actual flow of that vessel plus the collateral flow. The collateral flow, we have the leptomeningeum from the ACOM and from ALCOG. ALCOG test is the flow that goes through the PCOM through the ICA in a reverse flow. So the most important thing is always to try to all these calculations considering that the collateral flow is equal to 0. So the most important thing about this chart is that you can see like the post-bypass flow, example given the carotid, it's we need to reestablish at least 80% of the flow. So if we reestablished 80% of the flow, the remaining 20%, we can use the collateral flow, or the actual brain and vessels will compensate that and the patient will not have symptoms. So our goal is not 100%, it's only 80%. So as I told you, do we need graphs? Okay, talk about graphs, it's a whole topic about advantages, disadvantages, type of graph and everything. So I will just give you like bullet points about it. If we use an arterial graph, the principal advantages of it is that it's a better option because it's the same type of vessel. So we have a better match. And the important thing is that it's bidirectional. So because you don't have to worry about the bulbs. The disadvantages is it can have spasm or focal stenosis when you are harvesting this graph. So there are, here I put some examples. I know the artery that we most use is radial artery, but the patient doesn't pass the Allen test. We can use the mammary, the circumflex, the occipital, even the STA as a graft. And if we're going to use a venous graft for any reasons, one of the advantages of this is that we can use autologous or cadaveric. There are in very large institutions, there are cadaveric grafts that they give you, like the saphenous vein, in a segment that doesn't have bulbs. So these are things that can add up to your choice of graft. Other advantage is that it has greater compliance and greater distensibility. The disadvantages that we know is valves is more propense to thrombosis and it's unidirectional because of the valves. And also the important thing is that we can use any vein that we can harvest, we can use it as a graft. Okay, so grafts. As I told you, for many, many years, the principal point of bypass was, I want more diameter. I want that my anastomosis gets bigger, larger, and it's a huge anastomosis. But as we saw, that's not the most important factor. So that's why Professor Charbel says that we have to change about our thoughts about high flow and low flow bypass. We only have to use like graphs and divide them in high or low diameter conduits. That's it, because they are only conduits that will serve as a pass through the blood, nothing else. That graph will not, and that size of the anastomosis will not be the determining factor of how much blood is going to get to the other side from point A to point B. So, and also one way so we can know the minimum graft diameter that we need when doing a revascularization, we can do this simple, we have to multiplicate 0.9 for the diameter of the recipient vessel. And that's the minimum diameter that we need to achieve the 80% of flow that vessel is capable of delivering. Okay, so now, how do we execute this in a perfect way? So, because up to this moment, we already know the indication. We know how is the flow of the patient, how's the reserve of the patient. We know which will be my donor, my recipient, if I'm going to need a graft or no. The patient is in the OR. Everything of that was covered. How do I do the perfect bypass for the patient? So the perfect bypass for the patient is a bypass that allows to have less turbulence and less stagnation. And how can we do that? And how we can achieve a physiological wall shear stress. We can start by doing it by the angle that we use for the anastomosis. Here in my right side, you can see the 3 different angles of the anastomosis: 25 degrees, 45 degrees, and 60 degrees. The important thing here is that you can see from what is the heel and the toe of the anastomosis. When we use a 25-degree angle, the flow that is actually going through the vessel is the best one, is a laminar flow. Why? Because we are not creating a vortex in the toe of the anastomosis, because we have to remember that when the flow comes in here and hits this wall, the wall will create turbulence flow in here. But the important thing is, like, look in the 45 and 60 degrees, this is the actual flow. The lower part of the anastomosis is what is the actual flow running through that vessel. It doesn't mean that the anastomosis is not well done. It doesn't mean that it's not permeable. It doesn't mean that it wasn't constructed in a bad way. But the flow going through this artery is not as effective. So the brain will not use it. And if we have all of this, we have to remember, if we don't have a laminar flow, it is more propensious to create thrombus. And knowing this, that's why we need to do a donor recipient. The ideal is to have a perfect match. But the important thing is that if we create it in a good way, the body itself would regulate this. In how much? 180 days. So this is 6 months. The other point that I want to talk about is this viscosity. As we remember the high and possible low, we can manage all of those. But there's a test that they show us that the only way that the viscosity will affect positively to the patient is with a hemoglobin of 8. So the problem with this is that the patient can be with hemoglobin with 8. So the important thing is not to get transfusions to these patients. That's important because transfusion have been proved that they create thrombosis in the anastomosis. So the important thing is to prepare the patient for the bypass, so the patient through the surgery is not transfused and it can maintain a level of 10 grams through deciliter of hemoglobin. And the other thing, the endothelial surface, the only way that we can change it is using aspirin. But the important thing is that after 6 months, and as we can see in the chart, it doesn't matter if we create anastomosis with an increase or a decreased wall shear stress. And 180 days, the anastomosis will have a normalized wall shear stress as the rest of the body. So this is the time that we need to give aspirin to the patient. So there's no need to extend that treatment. Now, the execution, continuing with the execution. Okay, now I know that I have to do anastomosis of 25 degrees. So how do I do it? The most important thing is have a clean and dry fill. Mark the edges of the anastomosis and use the Ebert technique. As Tanikawa sensei told us, the perfect stitches are done by 4 and 2 T's. T meaning the wall part. So the important thing here is do an inverting technique so both endothelium can be in contact. The important thing, the other important thing is the square knots. We have to use the square knots because we have to remember, despite there are even 1 millimeter arteries, are arteries that have high pressure. So if we don't use the square knots, the anastomosis can fail. and our stitchings can fail. The important thing is to practice, practice, so we can do an average time per point about 1 minute. The other thing, the recipient artery. So as I told you, the recipient artery, we can calculate which is the best recipient and everything. The important thing is have a segment without perforators, so we can keep clean the anastomosis site. So when we're going to do this anastomosis, there are several things or things we have to consider. We can do it in an oval way, like we can see it in the image below. It's like Professor Shubin does it, like only 12 stitches, or we can use fish mouth as Tanikawa Sensei does it, and there are 14 stitches. And as you can see, all the stitches are marked with numbers because we have to do those stitches in a certain way so we can construct this anastomosis in a perfect way. The only difference between what this image and what nowadays Tanikawa Sensei does is like after doing the heel and toe stitches, he does the 1 and 2 the same, but he no longer do the 3-1 in the middle of the anastomosis. He continues with the 7 or the 4 because he told us that in that way, he can have more control of the posterior part of the anastomosis, and he can see also the endoluminal part of the anastomosis. So after knowing all of this, okay, I want to do an oval or a fish mouth anastomosis. In the superior right part, we can see how we can construct a perfect fish mouth. It's in a 60-degree cut, and we have to use the diameter of the vessel. That's the length of the fish mouth that we need to do. And here it's an extract of the bypass book of Professor Salim Abdul Rauf, where we can see how they calculate how much diameter we can use and how much radius it's going to have. The important thing here is that, as you can see, when you use fish mouth, we have more radius that it's going to be available. Another part or another anastomosis that I'm showing you because we'll have a discussion at the end of it, it's the side-to-side anastomosis. So in the side-to-side anastomosis, we can use the arteriotomy. The important thing is that this arteriotomy has to be at least 3 times of the diameter of the vessel, and it's in a curved shape. The image in the superior part is from Kamiyama book, so we can see how they do it. And the important thing about this anastomosis is if we fail to do this bypass or this anastomosis, we're going to lose both arteries. So we can have like principal or mainly 3 techniques. Kamiyama Sensei, that is a continuous stitch in the posterior part and interrupted stitches in the superior. The technique of Professor Abdul Rauf, that is, it's a complete continuous stitch in with only 1 suture, and Professor Morcos, that are 2 continuous stitchings in posterior and anterior part. What's the important thing to consider here? Where do I have to do the arteriotomy? As we can see here in a clockwise circle, if we do it in the 12th, like in the superior part of the artery, we will have better view of the edges, but we will have the worst apposition. The best apposition is at 3 at 9, but the problem of doing the arteriotomy in here is that we have the worst view of the edges, so the anastomosis will be really difficult. So what Professor Morcos concluded is that the best site of doing this arteriotomy is at 1:30 and 10:30. So just to have that in mind. So, okay, just like doing a summary of everything. We know the indication, we studied the patient, we did the perfect bypass, the bypass is running well. How do I do the verification that that bypass is working? So the first way they do it was a tactile way, but the problem with this is that they only see if the vessel was having pulse. The problem is that pulse is not related to flow. An occluded vessel still can pulse. The other way to do it is Doppler. Doppler is a really effective way, but the problem is that the Doppler only measures velocity, and velocity is not related to flow. We have to remember that velocity can change with the diameter, and it even increases if the diameter is smaller. Video and geography. Okay, here in Mexico, it's difficult that we have ICG, so we use sodium fluorescein. Actually, we can see here was what my professor and I described was the green tea. It's like a scale so we can know if that bypass is running in a good way, or what Professor Shubin described, the red tea with ICG, or even our patients or some centers that they use transoperative angiography. What are the problem with these kinds of verification? The problem with this kind of verification is that all of these only tell us about permeability, not effectiveness. So we know that anastomosis is permeable, but we don't know how much flow is running through that anastomosis. That's why Professor Chobal invented the flow probe. So it measures flow, not velocity. So we know the quantity of milliliters that it's running through that bypass. And using this, we can use afterwards and after the surgery. Okay, we can check, we did the surgery, our bypass is permeable, the patient went well and everything. How do I know that that bypass will work through time? And how much time do I need that to work? As we saw, at least 6 months. That is when the arteries and the body will regulate the wall shear stress and do all the compensation. So how do we know this? Using the cut flow index. What's the cut flow? It's the maximum flow of the donor vessel that can give us and the bypass flow. Using this, we can know, and dividing the bypass flow through the cut flow, if we have a cutoff point above 0.5, the patency rate through 6 months is above 80%. So that's the best way so we can know if that bypass is going to work. Okay, our bypass. What happens if our bypass is not working? Well, the principal reason after you study the patient and did everything of why that bypass is not working is mainly a surgical problem. So that's the first thing that you have to check. After that, if you see that it was not from the vessels of how you harvest or how you treated the donor and the recipient, you have only 2 errors in bypass. The first one, type 1, is no indication. So the patient didn't have the indication, or we failed to create the demand. And what I mean to create the demand is to create the delta pressure, the pressure gradient. And type 2, it's a technical error. The first one is type 2A, is when we use, or the problem is the donor. The donor was large or small donor, and we have these problems. Problem type 2B is problem in the anastomosis. And from all the types and well-studied patients, that's your problem that we have to check. We have to check that our anastomosis was done in a perfect way. And type C of error, the recipient artery, was not the perfect one. So what are the problems that we can have in these kinds of error? So type 2A, we can have hyperperfusion syndrome and subarachnoid hemorrhage because we're giving too much blood to that recipient. Type 2B, why we fail doing the anastomosis? Because we have poor technique, so we have to practice more. Type 2C, the recipient was not the perfect one. Well, we can have it in moya-moya disease on unconnected vascular regions, or we can use more compartments. So now I'm going to pass to the novel, or at least recent technique that it has been used to revascularize these kind of patients. We're going to start talking about the IMAX because I'm going to present you a case of a revascularization using the IMAX. So the IMAX, It's located in the infratemporal fossa. But what's the infratemporal fossa? The infratemporal fossa is a space under the floor of the middle fossa and posterior to the maxilla, specifically to the posterior wall of the maxillary sinus. The important thing of this is that it connects to the pterygopalatine fossa, that is the space that we're going to use to do this approach. So the important thing in here is that this space is surrounded by muscles. So we have to know these muscles. There are principal three muscles: lateral pterygoid muscle, medial, and tensor bell palatine. So the important thing, or the important one in here, is the lateral pterygoid muscle, because it has two heads, the infratemporal and the pterygoid. And what's the important thing, and how can we distinguish between them? The infratemporal head of the pterygoid muscle runs almost parallel to the floor of the middle fossa. So now talking about the IMAX is the larger terminal branch of the external carotid artery. And as we know, it arises from the posterior border of the mandibular neck. It has three segments: mandibular, pterygoid, and pterygopalatine. So the mandibular segment is where it's originated, and it ran along over the border of the lateral pterygoid muscle. So if we're going to do an exposure like that, that's the important thing about the lateral pterygoid muscle, because it's running parallel to the floor of the middle fossa, and we know that the IMAX is going there. The principal branches that arise from this mandibular segment is anterior tympanic, the middle meningeal artery, and inferior alveolar artery. From the pterygoid segment, we can see that it's less frequent, it has both heads, and it can pass through the lingual alveolar nerves. There are a lot of branches in here, sorry for that, D. And finally, the pterygopalatine, it's the segment with high tortuosity that go through the pterygomaxilline fissure. What's the important thing about this? All these segments, the important segment is the pterygopalatine and the pterygoid segment, because those are the ones that we are going to use to this. But as we know, always, if there's an artery, there are veins. So in this part of the infratemporal fossa, we have a superior and a superficial and a deep components of the veins. The important here is that the deep component of the veins go to the medial pterygoid muscles. So the important thing here is that all those veins go below the IMAX. So when we're dissecting the IMAX, if we start seeing venous bleeding, is that we are going too deep. So in that dissection, we pass through the IMAX and we are below it. So that's also a boundary that we can use. Okay, now that we know where the IMAX is, what's the history of IMAX bypass? The important thing is that the first description that they made about this bypass, or the feasibility of it was in 1996 by Briones. It was only an anatomical study where he described the infratemporal fossa, he described the IMAX and all its segments and everything. Until 2004, Austin did the first anatomic and technical feasibility study about it. It was until 2011 that Professor Abdur Rauf made the first case report of a revascularization using IMAX through the skull base. After that, in that same year, Professor Shi did 3 cases. After that, Nosek, 4 cases. Professor Juicy in 2016 published a series of 31 cases. And recently, Professor Detache in 2020 described a new technique of harvesting the IMAX, and he has multiple cases, but not serious. So the important thing is that we have many anatomical description cases, but very few in the clinical practice. So now to the exposure technique. How do we get to that infratemporal fossa and to the IMAX? I tried to make a recapitulation of all the techniques that are, or the most famous. So from Professor Abdur Rao, he drilled the skull base, as we can see in the images, and he drilled between the foramen rotundum and foramen ovale, so he can reach to the anterior loop of the IMAX. So the important thing is that he did a peeling or a partial peeling of the middle fossa and do the drilling in there. The problem with this is that if you go a little bit more medial, you will get to the sphenoid sinus, and that will change all the results of that surgery. Another way of exposure, because of how famous Professor Lawton is that he has published two techniques. It was doing two crannies. It was doing also having the middle meningeal artery, B3 and B2 as references. And he did two craniotomies. So he can, in the first one, he can see the IMAX or a loop of the IMAX. And after getting the IMAX below B3, he will extend that craniotomy to the middle so he can see the whole IMAX artery. As I say you here, 2.0 is the minimal invasive technique. So in this one, he used the sphenozygomatic suture through a regular terminal approach. And the important thing here is that he uses the inferior orbital fissure, and after that, he identifies the inferior orbital artery, because we know that that's a branch of the IMAX. So after he identifies that, he follows that artery in a retrograde way, so he can identify the third segment of the IMAX. And the last one is the Professor Amir Detashi technique, is that he uses the pterygomaxillary fissure as a way to get to the pterygoid muscle. That's the important thing here, because he does like a complete dissection using the index finger. He's not drilling the skull base, so we don't have the problem to open the sphenoid sinus and have fistula. So that's the big advantage of this. And as we can see in the images, the only problem, or what it's criticized about this technique, is the zygomatic osteotomy that we have to do. But as we saw, if we follow this fissure, we will get to the posterior part of the posterior wall of the maxillary sinus. We will identify the superior head of the lateral pterygoid muscle. And as we can see here, and as I told you, it runs almost parallel to the skull base. And when we cut this, we can harvest the third and second segment of the IMAX, so we can pull it to the skull base. So after knowing all this, I will present you like all of these. I will wrap it up with a case presentation in a patient that we have in here. So the patient is a 77-year-old man with a history of diabetes, hypertension, systemic atherosclerosis, and also 2 acute myocardial infarction that needed stents and repeated TIAs. So the physical examination revealed a left hemiparesis with a Daniel score of 3 of 5, and the patient was classified as a grade 2 of Rank scale. Here are some images of the patient. As we can see in the image, the patient had a generalized atherosclerosis, that this generalized atherosclerosis collapsed completely its right carotid. The internal carotid of the right side was completely occluded, and the carotid artery from the left side had 75 occlusion. And the patient had a minor stroke on the MCA territory, this temporal part. So the medical treatment of the patient included antiplatelet drugs, control of glucose level, blood pressure, using statins, and the patient continued to present TIAs. The patient was symptomatic about the best medical treatment. The patient stayed like that about 3 to 6 months, because they were increasing the medical treatment and everything, but the patient continued to fail to respond to this treatment. So what we did is we used a perfusion image using the CO2 test, and what we saw is that the patient had an increased time to peak and increase in mean transit time. So, and also a decreased regional blood flow in that part in the territory of right ICA. So now, using this case, as you can remember, I mentioned 5 points that we have or we need to have for a bypass surgery. So first of all is the first, what's the indication? So in this patient, if I'm going to do a bypass, the indication is flow augmentation. Okay, why this patient need more flow? Because this patient presented 3 conditions. First of one, the recurrent TIAs. Second of all, a hibernating brain. Why is that? The patient was unable to stand or walk or getting upstairs or downstairs. Why is that? Because in the moment the patient was requiring more blood, that motor cortex immediately shut down. So the patient was oscillating in a state of between oligoemia and ischemia. The important thing is that all of this we can prove it through the perfusion MRI. So the goal in this patient is to reestablish regional blood flow, glucose metabolism, and restore the functional state caused by chronic ischemia. When we do this, we do a regression of the hibernating brain and the resolution of the hypoperfusion of this part. So now, how much flow do I need? The whole MCA territory has around 15 to 40 milliliters of through 100 grams of cerebral tissue. So remember, the important thing here to remember is that collateral flow must be calculated at 0 because that patient, as we saw, he was barely standing there with that flow. So now I will introduce you to 3 things, or what I try to call the triple check of bypass. So the triple check, the first one is the donor. So what will be my donor? Why IMAX? Why not STA? I know that STA is the principal donor for all of these cases. And also it's the principal and one of the easiest ones to harvest. And it's not, we don't need an zygomatic osteotomy. We don't need a graft. We don't need anything. But what's the problem? In this patient, and specifically, the STA was really, really small. And it had only one branch was feasible because the other one was occluded because of the atherosclerosis. So when we saw that, we saw the IMAX. And we start reading and everything. We do our background check and everything. And the IMAX provides around 60 to 95 millimeters of blood. So it's enough for the MCA territory. So after we know this, we check the recipient. Okay, which artery will be the best recipient for us? We have to remember the main symptom, and as I told you, the main symptom of the patients with hemodynamic failure and atherosclerosis is the motor problem because of the hibernating brain. So the main symptoms are related to the motor cortex. And we have to think, okay, if the problem is in the motor cortex, which arteries go to the motor cortex? So the principal ones are the precentral and central arteries. And where do they come? Most of the cases, it comes from the dorsal branch of the MCA or the M2. So now we know which will be our recipient. After that, I have to know the reserve. How's the reserve of my patient? Here are the MRI images of the patient. We can see in the time to peak and middle transit time, the whole MCA territory, it's in hypoperfusion. These are the tests after vasodilatation test with the CO2. So here we can see that all that territory, the MCA territory and the watershed territory is completely lost. The patient will not, well, the patient doesn't have blood enough in this part. So now in this triple check, as I told you, do I need a graft? Well, if I'm going to use the IMAX, yes, I will need a graft. So what's the perfect graph from here? We use the radial artery. Which were the reasons why we choose this one, and what were the advantages that we thought about it? It's an appropriate diameter, and it's similar to the M2 diameter, so we can avoid a type 2 error, lack of valves because it's an artery, less possibility of kinking. Why do we have less possibility of kinking? Because the distance between the infratemporal fossa to the sylvian fissure where it's located, the MCA, it's not long. So if we have a short graft, the important thing of having a short graft is that we avoid the possibility of kinking. So as I refer here, the final length of the graft was 7 centimeters, and it was a completely adequate length from the temporal fossa to the sylvian fissure. And what approach do we use for this? Okay, we selected the approach described by Professor Peto and popularized by Professor Detache. So here are some images of the case. Like in A, we use here Mayfield position. Well, the head holder of Mayfield. We use a almost traditional pterional approach. We mark the graph for the STA. Number C, it's the harvesting of the STA. D is the proximal anastomosis, E the distal, and the final check. But now I will show you this video. Okay, so here is the after the approach, after doing the osteotomy. Well, in here we can see that we find a distal branch of the IMAX artery. So when we check that artery has a good flow with the Doppler, the next thing is that we start a retrograde dissection, because we have to remember that in here we are in the third segment, but the important thing is that we need to cut the artery through the second and third segment. Here's the drilling of the skull base and the middle fossa, so we can shorten that part. Here we are dissecting one branch of B2. After that, we did the cranny and everything. We open up. We start with the dissection of the sylvian fissure. In here, most of the cases we use like cutting dissection. So in here, we identified the M2, the dorsal branch. We can see in there the MCA bifurcation. And why do we use the dorsal branch? Because we saw and we studied that the principal recipient artery were central and precentral arteries. In here, we have the radial artery harvesting. We have to remember that the artery doesn't need to be cut until everything is ready for the anastomosis. So in here, we are doing the ligation, the proximal and the distal one. We also like to mark the artery to know which part is the dorsal one, so we can use it almost in that way. And as you saw, we leave the silk kind of long in the distal way, so we can know which one that was distal and which one was proximal. In here, we are doing the temporal occlusion of the IMAX and cutting it. We're coagulating that part. We're taking out the clips. And after that, we will pull the IMAX from the infratemporal fossa and the pterygo to the skull base. So we start dissecting everything and we can pull it all the way up here. So because we don't have like a dam like the other one for this, we use a glove and we mark the edges. And now we'll start with the proximal anastomosis. We can talk about, and we will discuss it afterwards, which anastomosis we have to do first, the cerebral one or the one from the donor. And we will come back to that later. And after doing this, I saw that the match was almost perfect. So I did just a little fish mouth, and I started with the stitches, doing the heel and toe of and our anchor stitches. The important here is that for this anastomosis, we can use an 8 or 9 prolene, and we prefer to do separate stitches. We think it's better in this kind of patient, so we can allow that if that the patient needed, the graft will distend and it will have more flow. Okay, and after doing our stitches, our boat anchor, we will start doing all the stitches as the way that we describe. We'll start always, Professor Tanikawa always tells us that start and your first stitches they have to be next to the anchor. So we can close that part. So in here we can see that we're continuing with all stitches I did. First, the ones that I had in the first part. And after that, I completely rotate the graft and continue doing all the stitches in here.
Iya. Padahal pengen lihat ya. Padahal pengen lihat. Iya.
And after we finish the anastomosis, we're going to cut that glove and we're going to check our cut flow. So we open the graft so we can measure how much blood is running through that graft. After we check that we have a good flow, we flush out all the blood. We cut the graft. As I told you, the final length was only 7 centimeters. And then we mark it again and started our second anastomosis. Here we use a linear. Actually, if you can see in there, the whole wall of even the MCA, it has atherosclerosis. So we try to select a part that it had less atherosclerosis, so we avoid the failure of that. The important thing is that if you see a vessel that like this, you have two options. You can do like an endarterectomy, try to take out that plaque, so you can do a cleaner anastomosis. But if you see that you can take out that plaque, you have to include that plaque with the stitches. So you can, like, with the same stitch, join the vessel wall and the plaque so you don't cause stroking here. I mean, for time reasons, I will just like move forward. We finished here the anastomosis, and after that we release the distal clip, then the proximal one, and we check that the graft was good. And after doing that, we have to remember that to this point, the flow growing through that graft is from the MCA. And in that moment, when we open everything, the flow was reverted. Now the flow is going through the IMAX, through the graft to the MCA. We're checking it with Doppler. We're checking all the branches. And then we use the fluorescein to do the final check. And we see how the graft starts. And after that, the anastomosis and the cortical flow. After that, we finish the anastomosis, we close and everything, okay? So, because we know what was the diameter of the graft and the flow, because we open freely the IMAX and know how much was the flow. Okay, after that, we do a transcranial Doppler, so we can know the velocity of the MCA and the velocity of the radial artery graft. And when we know that there was 334 millimeters and 288 millimeters, when we calculate this, the cut flow index is of 0.86. So meaning the bypass has an 80% chance of long-term patency to 6 months. So these are pre-op and post-op studies compared. So we can see that the only part that we left after the bypass, the compensation was the watershed part between the MCA and the posterior cerebral artery territories in here, in the occipital part. But we can say that almost all the territory of the MCA was reestablished. Here are the angio-CT images of the post-op. We can see the arrows show the sites of anastomosis. And you can see it's a really short graft. And the flow that goes through that graft, it's a really good one. So here are the final image. I asked the patient for the permission. The patient was unable to walk. He was in a wheelchair. He can't do anything. He arrived to the consult. This is like 2-month consult. As you can see, the patient, it's really doing well. I mean, this is in Spanish, and he start talking because he had the dysarthria, but now he's talking, he's laughing, he's doing everything. And in the final, well, the 6-month check, he was walking perfectly. So what are the alternatives that we have if we are not using an IMAX? We know that we need to reestablish the whole MCA territory. So we can use the well-known double barrel, or there's a more recent technique also created by Professor Charvel and like perfected by Professor Morkors, that is called the Minimax, or the 1D2R, 1 donor and 2 recipient. This is a extract of their article. It's the one that it's referencing down the slide. The important thing here is that they prove that if we do an side-to-side bypass to the temporal part and then an end-to-side bypass, we are creating a in-series circuit. Because the thing is that Professor Morkos joined the Hagen-Possible law with the Ohm law of electrodynamics. So when he joined that, he discovered that if we create more anastomosis to the only one donor, we are creating an in-series circuit. If we create that, the whole resistance of the system will go down. And if the resistance go down, that means the pressure will go down. So if we create a less pressure circuit, we will have a better delta P. So that's why he created this. And after this, he created 2 things, the SARA and SASI. And it's how the cut flow, it's measured through the first anastomosis and through the second anastomosis. And just to wrap things up, I will leave you this. Great things are not accomplished by those who yield to trends or fads or popular opinion. So I think that us vascular surgeons, we always have to be pushing the boundaries, doing great things, but also with indication and everything, and always having in thought that all that we need to do is for the patient. So thank you so much. This is a photo that I took with Mohammed and our dear friend Shannon in Tenshinkai, and this is a photo of Mexico City. So thank you so much. If you have any questions for that, I will be happy to answer them. Thank you so much.
Thank you very much, Javier. That was an amazing lecture, and we have 155. This is a record, a new record for this year webinar that we have held.
Okay, that's nice.
Yeah, we start with 20 and now we have 155. So I hope you still can stay with us for discussion, because I believe there must be a lot of things to ask. Me myself want to ask a lot of things, but let's.
Oh yeah, I'm open. Don't worry. I free my schedule for you.
Thank you
So
so much.
shoot.
I will invite the panelists here to join the discussion. We have some other panelists that has joined us, and we have Dr. Professor Shannon Aryapakai from Bangkok here. So glad to see you, Professor Shannon.
Oh,
We also have Dr. Abrar Arham, our head of department in my hospital. We have Dr. Anugrah Oni, the chief of vascular neurosurgery in the city of Palembang. We have Dr. Bambang, our head of neurointervention in my hospital, Dr. Bilzardi Ferry. Thank you for joining us from Bandung. And then Dr. Doni Ardi from the island of Nusa Tenggara Timur, from the city of Kupang. We have Dr. Hasan Barakba also from Bandung. Dr. Marjono Cahyadi from Jakarta. Thank you for joining us. Dr. Tondi. Dr. Tondi from Pekanbaru, thank you for joining us. So please, panelists and attendees, if you want to ask some question or have some discussion, please write it down in the Q&A box or in the chat box. And for the panelists, just turn on your microphone if you want to ask some question. So maybe before the panelists okay, we have someone raising hand. Dr. Krishna, it's 2 a.m. in Italy, but I see you are raising your hand, so you're still awake.
yeah.
Go ahead, Dr. Krishna. Thank you.
Okay. Thank you, Dr. Kostiansa, for the opportunity. So, first, congratulations for the presentation. It's really nice.
I think we are losing you, Dr. Krishna.
Is this reliable to do it in acute phase, or you can just go with only the chronic phase?
So, Dr. Krishna, we kind of lost you for a few seconds, but let me repeat the questions. You are asking about the technique of IMAX bypass.
No, the timing of doing the anastomosis. Is it good to do it in acute phase? So, well, actually, last week before I went to Italy, we have acute infarct stroke patients, and we failed to do the thrombectomy, so it was not a good TG outcome, and we go directly to the low flow bypass using the ST and MCA bypass, but the result, the outcome is not favorable. It's not so dramatic change. So what do you think about that?
Okay, so in the acute state, the important thing is the timing. I mean, we can catch it like in a well state the patient, and when the bypass, if we use a IMAX bypass in this case, the problem is that we can have bleeding of reperfusion. So if we take it in an early time, like first 6 hours and everything, the ischemia hasn't disrupted the blood barrier. So if we can, or we know that that barrier is not disrupted, we can use the IMAX, because the IMAX will give us enough flow to reestablish the flow to the whole MCA territory. The problem is the flow. The flow is too much. So if the brain blood barrier is lost, that will cause a reperfusion hemorrhage. So that's why in those cases, if we don't know, that's why it's better to go safe with the STA. But what we can use in those cases is the Minimax. Why? Because if we do with one vessel, it's not going to be enough flow. But because we have two anastomosis, the two anastomosis will auto-regulate the pressure in that area. So it doesn't matter if the blood barrier is lost. So if we do that bypass, it can be, but I mean, if we have a stroke patient that started like 1 hour ago, he get in the angio suite, they couldn't do the reperfusion and everything. We try, the protocol that we have in here in Mexico is if the endovascular team fails to reestablish flow, that patients go directly first to try surgical thrombectomy, like doing clamps, open up the artery, take out the thrombus or the occlusion, But if we fail to do that, we are ready for a bypass in that moment. We don't take second chances, or we don't wait. Like if we don't can or we can see a perfect blood flow in that moment, we immediately do the bypass. So in this case, if it was a patient that was in good conditions and everything, I will go with the bypass or a minimax, because they will give me enough flow for the whole MCA territory. So if that's the case, yeah, it's safe to use the IMAX. The only thing that we need to have in our mind is the brain-blood barrier, that is not disrupt. So the vessel and the brain can handle that much flow. That's why if we do it in an earlier stage, that brain-blood barrier will not be lost. I hope that answered your
Thank you.
question.
Yeah, thank you. Thank you.
Yeah, thank you. I think the Minimax idea it's ideal because during the acute phase it's really hard to predict. There's minimum information that we have. So by using the Minimax and taking the advantage of autoregulation of the vasomotor reactivity, it's not only giving a lot of coverage of the ischemic area, it's also protect the brain. And it's faster to harvest one artery rather than doing a double bypass, because it's all about timing. We have another panelist raising hand, Dr. Marjono Cahyadi. Please go ahead.
Yes, thank you, Dr. Kus and Dr. Digolado. Nice talk. So my question is following Dr. Krishna question about the timing of doing this bypass. Well, if we use this bypass for the chronic atherosclerotic with TIA, what do you think is the best time to do this bypass after the attack, the TIA? And second question is, in your case, why do you think? Because we know that we only need the flow augmentations for your case, and we know that you only need like 40 to 50 cc augmentations for the blood flow. So I think for that augmentations, the STA single barrel, if you do it good, is just enough. So at that case, why did you consider to do the IMX, we so-called the high flow bypass for that augmentation?
Okay, yeah. Well, in this case, as I told you, the patient, because of the generalized atherosclerosis, the parietal branch of the patient was completely occluded through the atherosclerosis. So the diameter of the frontal branch of the STA was really small. And the other thing is that we have to remember that patients, when they get sacrificed from the STA, the site of the craniotomy and approach, it's more propense to have infections or problems with the healing of the wound because of the flow that is not going through that part. So that was the main reason. As I told, the reason it was the STA wasn't available. So we thought like, okay, we can use the STA. So which other we can use? So that's why we like use the IMAX. It was like, I mean, it's not like the first bullet you or the first option that you need to have for these cases, but you have to know how to use it if the STA is not feasible. That was the only reason that we do it. And also because when as you saw the pterional approach, we did it and we check in there. So actually, when we check in there, part of the main branch of the STA was calcified. So we say like, no, this artery won't give us enough flow to reestablish flow in this part. And answering your your first question was, when's the perfect timing? As I told you, the timing is, and the indication is not only one TIA. The patient have to have all these three criteria, like recurrent ITAs, ultraperfusion, and best medical treatment in a good way. So what we have here with the vascular neurologists is that they like study the patient and treat them in the best possible way around 3 to 6 months to see if they actually get better with the best medical treatment. And most of the patients get better. But as I showed you, a lot of studies show us that despite all the best medical treatment, the patient is doing well, it's taking care of himself. Some patients want the answer to this. So in these cases is when the bypass can help us.
Yeah. I do agree. If the condition that the STA, in your case has some atherosclerosis as well as disturbance, we have to find other alternatives. Yeah, I do also agree that this is the difficulties of we keep bypass surgery to treat the atherosclerotic disease, because if you read the latest study, this CHIMOS, do you know the CHIMOS study?
Yeah, the
Uh,
CMOS.
yeah, that's also bring dissatisfaction because a bypass study didn't give any significant difference from the best medical therapy. So it's our problem now to find the best candidate for the
Yeah,
bypass therapy.
yeah, exactly. If you, after the lecture and everything, I will share with Mohammed all this because as I show in my slides, to the CMOS study, actually, Professor Lawton, Professor Shubin, Professor Baskaya did a note about that study and why it was not well studied for those patients because they put in the same sample carotid occlusion and MCA occlusion, and we know that those are not the same patients because the gradient of pressure that we know that we need is different for a carotid occlusion, knowing that the pressure goes from the carotid to the MCA rather than an MCA occlusion that the flow is inverted going from the M4 to the M1. So that bypass configuration and that flow that we need and how we create that bypass and the indication is completely different in those cases. And also the reason that why they disagree is because exactly most patients were not completely studied, they were not followed, and they only follow patients for 3 to 6 months. So they tell that okay, most of these patients and the patient that they were put to the bypass protocol, they were not followed through and they were not like they don't have like a complete criteria and they use not only the perfusion, they say that you need to know the vasoreactivity and the reserve. That's the most important thing. I mean, I'm pretty sure you know Professor Bakowski from Berlin. He's an expert in Moya Moya, so he always says like, yeah, the reserve. The most important thing is know how's the reserve of our patient, because if the vessel is it's done, I mean that's the patient that we need to help. If the patient can still go through vasodilatation and everything, it means that the stage of hypoperfusion that he is not indicated for bypass. So, I mean, that's another important thing. And after all of this, I will be happy to share that article with you when they do the answer for this. And they say like the problem with this, and well, they let us know that the problem of all these trials is that they are not made by actual vascular surgeons. Like it's most neurologists and vascular neurologists that they say like, okay, we will have all the patients with atherosclerosis and we will study all of them. And if they get better with bypass. But the problem is that bypass is, as I mentioned, is only for the 10% of patients of atherosclerosis that have an hemodynamic failure.
Yeah. I do agree with your comments. Also for the CMOS study, they also picked the carotid occlusion, which is different game with the MCO occlusion. Yeah.
Exactly.
Okay. Thank you, Dr. De Golado and Dr. Kustiansyah.
Thank you so much.
Thank you. Thank you, Dr. Joy. So, is there any more question? I will go through the Q&A box. We have one question here. If any panelists want to ask a question, please go ahead and raise your hand. So the question is from Dr. Julius Hermanto. He's now actually a fellow at Taisin Kai. So this question is, how long is your sleeping time before the chronic hypoperfusion? Is there any trick in how to prevent graft thrombosis? Okay. Maybe what he means is the clamping time, temporary clamping time during the procedure.
Okay, the temporary time or the occlusion time, as we know, it's like around 10 to 15 minutes. As Tanikawa Sensei told us, it doesn't matter if you take hours to prepare all the field, to prepare the graft, to prepare everything. The time will start counting when we put the clip. So that's why we need to prepare the field, as they told us, like putting the dam, putting the gel foam, putting the everything so the field is clean and everything. So the clamping time around this anastomosis, for the IMAX anastomosis, were around 10 minutes, and from the anastomosis on the MCA were 12 minutes. We have to remember that these bypasses are, in technique, they are simpler than an NSTA because they are larger. So the suture that we use is larger. As I told you, for the IMAX, we use an 8 or 9 Prolene, and for the MCA, we use 9 or 10, preferably 9, because as you saw, the diameter of the vessel, it's pretty large. So the 9-0 suture can handle that kind of pressure. We don't need the 10-0. So if we have a larger suture, the stitches will be a little bit bigger, so we need to do less stitches. So it's not an important thing about that. The important thing that we need to remember is that when we use a graft, the graft doesn't have to have flow through it when we have the temporary occlusion. What I mean with that is that, as you saw, after I did the anastomosis, I put a temporary clip just above the anastomosis. And then I flushed down the whole radial artery and then put another temporary clip that will have or will contain the heparinized solution within the graft. Because if we let that the graft is open and only do the occlusion, it will thrombose because that blood is not going anywhere. So we need to do that so we avoid the graft thrombosis.
Okay, thank you. So interesting question. Because the recipient is more proximal, I think timing is quite important. But would you agree if I say that for an augmentation to the M4, I mean, you can do longer ischemia time, because this is what always prevent people from start doing bypass, is they're not confident with their ischemia time. But would you agree if I said that ischemia time in the M4, you can do like for even 55 minutes, as long as the field is clean, and also you can. This is also another comment I'd like you to say what you think, is to increase the blood pressure, the mean arterial pressure about 10 to 20% during the clamping time. And regardless the timing, you can do probably in the worst case scenario like 1 hour of clamping time in the M4, and that will probably still be okay as long as you can maintain a good flow afterwards. Because when you try to do very fast and then you ended up enduring the intima or not doing an aversion bypass, and then you clamp the recipient for nothing. What do you think?
Yeah, exactly. I mean, as Tanikawa Sensei told us, the important thing is not to be fast, is to be perfect, because one stitch can ruin the whole bypass. As you say, it's preferably to take 20 to 25 minutes and you do a perfect bypass than doing a 10-minute bypass and you have to check it, you have to reopen it because the bypass is not flowing. And the other thing about you told us, yeah, in this kind of patient, the ischemia time is longer. One thing that I failed to tell you guys is that in these patients, we need a good anesthesiologist. Why is that? First of all, because of the things you say, we have to get the blood pressure a little bit higher when we do the temporary clipping. But the second and the most important thing that we or some series don't take in consideration is that if our anesthesiologists, when these patients arrive, we know that this patient is with, as I told you, in stage 3, so they have the whole vasodilatation. But if this patient, when goes through surgery, they lower the PCO pressure that they are used to because they use oxygen to the 100% and they change that, the vessel will contract. So the patient can have a stroke even before the surgery starts, just for that change in PCO2 and O2 concentration in the blood. So that's one thing that you have to take in consideration and talk to the anesthesiologist. Like, yeah, I know that you have to go through oxygen. I know you have, but please, please don't change that much that gradient. Yeah, the patient will be with hypercapnia, but that's how the patient is used to. If we change that, the vessel will contract and that part of the brain will get a stroke.
This is very important point because a lot of studies and series only talk about the surgeon part and the physiology part. They didn't include anesthesiology in the quotations. So very important. Thank you very much. And while waiting for another question, also about the prevention of thrombosis. This is very interesting, interesting and yet important point to make, because if you see there's a lot of video in YouTube, and now people like they want to do bypass and they go to YouTube, and then I saw some video that they didn't really care about the sequence of putting the temporary clip or the position of placement, because as you say, stagnation will cause thrombosis. So we have to prevent stagnation. If the blood flow is go to a stump where you put the clip in there, it will thrombose, and when you open the clip, the blood will flow to the anastomosis perfectly, but the thrombose is going to the distal and cause a problem. So I think the heparinized saline and keep the heparinized saline inside the lumen is very important. My question is, you told me that you put the proximal temporal clip just above the bypass. So yeah. So, and then I just want you to summarize what you say about the thrombosis prevention thing, because this is very important. So the proximal temporal clip is just above the anastomosis, and then you fill the lumen with heparinized saline, and then close the distal part.
Yeah, I use 2 temporary clips, just one above the bypass and the other pretty near where I'm going to do the second anastomosis. As you say, to leave the heparinized saline in the graft through the anastomosis. And after that, it's what I also told you, that they do the intention care. Like, the way you take out the clips is important, because as they taught us, you have to take first the distal one. The distal one will show you if that anastomosis it has a good permeability and it's not like having missing stitches. The second one, the second clip, will open you and will give you the real pressure of that anastomosis, because that's the proximal flow. And the third clip is the one that you have in the graft that will mix the blood and mix the heparinized saline through that anastomosis to flush it out. And after that, when I checked that everything that was running perfectly, that's when I changed the flow. That's when I opened the IMAX. After I checked that all that system was running well, then I opened the IMAX so I can invert the flow. So the flow is not going through the MCA to the graft. It's going from the IMAX, graft, MCA.
Yeah, that's very important, this sequence. And you do one step wrong, it will ruin it will ruin everything and create a new truth. So very important thing. Uh, is there any other question from the panelists? I see here. We have Professor Juan Carlos. Professor Juan Carlos from Cucuta. Are you with us, Professor Juan Carlos? Probably it's late in.
Not Mohammed. It's okay. Thank
Hi.
you. Congrats, Javier.
Yeah,
Thank
yeah.
you so much.
It's good to see you again. It's this nice small reunion. So yeah, maybe you wanna have a comment or a question, or just want to say hi to Javier. It's been a while. Dr.
Oh, thank you,
Shannon.
Mohammed.
Yeah, please go ahead. Go ahead, Juan.
Congratulations, Javier. It was a good presentation. I don't have comments.
Thank you so much, Juan Carlos. Nice to saying hi to you. I hope
Thank
to
you.
see you soon in Chile. I mean, it's way closer from Colombia than from Mexico.
Yeah. You are in the same part of the world, like me and
Yeah, I
Shannon.
mean,
We should meet up. I should meet up with Shannon because we are very close. So in January I'm going to Bangkok. You should visit each other. Dr. Shannon, do you have any comment or question?
No. It's a very great presentation and very inspiring. And nice to meet you.
Yeah, it's good to see you, Dr. Shannon. I have some question, and I really want people, especially in Indonesian community, to really understand this. This is about the preoperative preparation, and our problem. Probably we have the same problem. I don't know with you, Dr. Shannon, but it's difficult for us to measure the CVR because we do not have intravenous diamox. So measuring the CVR with the well-known technique, the popular technique of giving diamox is it's impossible to do, and it is surprising that to know that Professor Subin also doesn't have diamox in China. So I I haven't asked him how to measure the CVR, but I see in your slide interesting way that you do transcranial Doppler VMR with apnea test. I think that is something that we can apply anywhere in the world, like any part of the world. If you have transcranial Doppler, you can do it.
yeah,
So
the important
could
thing
you
is that you
explain
can
more
also use
detail?
it for the MRI. If you have an
MRI.
anesthesiology, you just have this actually the Zurich protocol, it's called. You can Google it like that. It's the Zurich protocol of CO2 test for these patients that or countries that don't have diamox. They compare diamox to CO2, so it's almost the same result that they have. The important thing is just to keep the patient with a high pressure of CO2 for it can be with apnea test, and if they because the apnea has to be of 45 seconds to 1 minute, so it's not a great challenge. But if they can do that, the other way to do it is just like put something in the patient's face, let them breathe their own C2, and that will be enough. So that's a good way if you don't have diamox, as I do in Mexico, there is not diamox. So that's the way that we check that in the MRI, and also we can double check it with the vascular activity with Doppler. So you just make the patient do the apnea, and you will see in that point how the velocity changed, and if it changed, how much. So it's a really good way to know that perfusion studies and the reserve that our patient might have without using diamox.
Yeah, it's very practical, and I think you can do that anywhere. I'm just curious, Dr. Shannon, how you do CVR, how you do CVR evaluation pre-op for.
I don't have Diamog tool.
So do you just like go ahead with CBF? Go ahead and bypass with. That's what I do in.
Yeah, yeah, it's the same, the same.
Like best medical, it's super simplified. Best medical therapy, recurrent CIA. CBF is normal. I go ahead and do bypass. CBF is low. Of course, we do bypass. CBF is normal, but recurrence that recurrence TIA with best medical therapy, I will still do it. Now we can probably we can do what Javier do. It's very simple, and you can do that with transcranial Doppler of EMR. Sometimes perfusion study is expensive, even for MRI. So we have to select which modality that we want to use. If we want to do CTA and DSA, then CT perfusion will be too much in terms of budget for the hospital. So that's the difficulties we have in Indonesia, or maybe in a lot of part of the world. We have another question from the panelists. First, Dr. Tondi. Dr. Tondi, you raised your hand. Go ahead and unmute yourself. Thank you for joining us, Dr. Tondi. Dr. Tondi, you are still muted. Please unmute your microphone. Okay.
Okay, thank you.
Yes.
Thank you. It's very good presentation. Dr. Garcia, I have listened for your presentation, but I have a question for you because if we go to this procedure, we afraid about the repercussion injury after or during the procedure. How do we avoid the repercussion injury during or after we perform the procedure? Thank you.
Okay, well, that's important thing of what I told you is the pre-op study of the patient. We know, as I told you, we have to know the reserve, we have to know the recipient, and we have to know the donor. So to avoid the reperfusion injury, as I told you, it will be a mistake 2A. So as I told you, the failures of the bypass. So to avoid this is trying to do a perfect match from donor to the recipient to avoid that. And one practical way that we can see that through that graph it's going through a lot of blood is if the patient start presenting after the bypass subarachnoid hemorrhage, because that means that the pressure in that area is too much, so it's breaking the vessels. What we can do as a salvage movement in there is what Professor Morcos and Professor Vizcaya described. Is like doing stitches in the proximal part of the donor, so we can reduce the diameter of the donor. So it will be going less blood through that graft, and the subarachnoid hemorrhage will improve. That's one way to do it. And if we close up and everything, and the patient wasn't like symptomatic, and he presented the reperfusion syndrome or hyperperfusion syndrome after that, well, we have to do what is described. I mean, we have to give the patient like blood thinners, stabilize the pressure and everything, because we don't want that pressure goes too high, so it can provoke intraparachyndematosus hemorrhage or intracerebral hemorrhage. So those are the ways, and that's why I told you like the 5 points that I always tell residents and other doctors is like the success of the bypass surgery, beside the anastomosis, beside the technique and everything, is to study well the patient, so we can give the patient what the patient needs. And the bypass is like it's really beautiful in this case because even it's a regular STA bypass, it's not the same bypass for everybody because you can tailor that bypass. You can use the bypass with a normal oval shape, head of snake, I mean like fish mouth and everything. So you have to tailor that for the needs of the patient. I mean, that's the way to prevent that. Once it started or it happens, I mean, there's not much that we can do because, or the other thing is that the patient is really symptomatic. It had a big hemorrhage. Well, we have to deal with that. And in that scenario, we will have to consider doing a partial occlusion of the bypass that it's already flowing or stenose it.
Thank you.
Yeah, thank you very much. And thank you, Dr. Tondi. And as Professor Charles said, the technicality for bypass is much more simpler, or like the physiology is much more difficult than the technicality. So the bypass itself, I believe, serve a very small percentage contribution to the patient outcome rather than the study, and post-operative care is very important as well. So yeah, we have another Dr. Joy. You raise your hand, please unmute your mic.
Yes, it's interesting to discuss about the CPR because I think this is the key of the why many studies in the past failed to prove the efficacy of the bypass. So I really want to stress out this CPR because we don't have diamox as well. So have you ever heard about this physical activity task during the MRI? And you said that you do the technique of increasing the PaCO2, right? So
Yeah.
my question is, what is exactly the technique you do? How big is the level of PaCO2 you make? And if you ever heard about the physical activities and then you measure the PaCO2, how do you do it? Because I think that's important.
Yeah, okay. Well, the way we do it is like with the help of the anesthesiology team, they monitorize the patient. So what we do is like they plug in like a capnographer to the head mask of the patient. So the patient is start breathing his own exhalation. So we increase the CO2 level up to the level that the patient can tolerate it. So if the patient start being dizzy or having symptoms, they start putting oxygen to that system. The thing here is that that's the problem of this. We don't have like a specific, or it's not defined in the literature or in papers, which is the perfect level of PCO2 that we need to create that effect. Also in the apnea test with transcranial Doppler, they say like 1 minute of breath holding is enough, or 45 seconds to 1 minute. But none of the studies tell us like you need to increase the PCO2 for that or that amount of millimeters of mercury. So in that, I'm sorry, but I don't know how much PCO2 that we need. So in this case, I just use it like as much as the patient could tolerate it. And about that test that you do with physical activity, I mean, that's the same basic principle of it. Like you use the physical activity so the patient get vasodilatation and everything. And with that, you can evaluate the reserve. We have to get the idea that the important thing is not only to do this test. The important is to compare them with vasodilation and without vasodilation. I mean, we have to make two tests, the basal one, that is the regular state of the patient, and after the Diamox or PCR2 or exercise test. We have to compare them, and we have to know how much is the variability of this. That's the key, not only doing the PCR or the Diamox or everything. We need to have both so we can compare and see how much does it changes.
Yeah, yeah, yeah. I agree. Thank you, Digolado.
Yeah, you're welcome.
Thank you, Dr. Paul, for the question. And I think the argument also applies for the Diamox test because you can clearly say about the, sorry, can someone mute the,
Ambil kontaknya.
uh,
Kamu mau? Oh, kamu kan dijaga apa?
okay. So yeah, I think the argument also applies. I want to hear what you think about this, but the argument also applies for the Diamox test because it's not as simple as giving the Diamox and then lower the flow to the hemisphere because each patient would respond differently. You know, the current blood pressure during the study and then the the collateral flow. So you cannot you say you cannot do an exact number of PCO2 that will cause the effect. I think that's also applies for the Diamox test. The thing that we should really care about is to compare the to see the result of that protocol and then breath holding for 45 seconds for each patient will result in different response as well. So it's always hard to it's always I think it will always hard to predict whether the because the main question of CVR study is to predict whether the bypass will be useful in the future, right? So yeah, it's the main problem that we have.
Yeah, that's the reason why we have like 3 different parameters to that we have to check box to put these patients to the bypass, like the clinical one, the perfusion test, and the symptomatics about that they have despite the best medical treatment. So if the patient doesn't meet the three criteria, the patient is not candidate for surgery. So I mean that if we could have like the exact number of PCO2, the exact number of flow, exact number of everything, I think the clinical and maybe the best medical treatment will have a less important role in here because we will know it for fact. The problem is that, as you said, we don't know the exact numbers for every patient. So we need to have like
Bentar ya,
several
keplek di sana dulu ya.
so it could help the patient.
Cuma itu generous banget.
Uh, can the host mute the panelist, please?
I think you're muted, Mohammed.
Okay. Yeah, I think that's the challenge that we are facing to I think studying the CVR is part of us being responsible for the patient. We don't want to just go ahead and bypass. We have to be really sure whether the bypass will be useful for the patient in the future. So I think you can use whatever means of modality that you have, but as long as the aim of the study and the aim of your surgery is to help the patient, like you say, patient outcome is the most important thing. We have to avoid the danger of wanting to do bypass. We want to do bypass and then we disregards the indication, we disregards the study. We go ahead and do the bypass just because we want to do the bypass, and that is harmful for the patient. So yeah, I want to encourage the young neurosurgeon here to start in the participant. We have 148 participants now. To encourage them to start studying the patient, finding the indication, and doing bypass in the right way. because the thing that matters most is the outcome of the patient.
Yeah, and also we have to understand that this surgery is to help the patient. As I show in the slides, the main problem is the motor problem. That's why we prefer to do the bypass to the central and pre-central arteries. Because I mean, someone can say, okay, I can do that, all that, but I don't want to do the anastomosis to the dorsal branch of the MCA. I want to do it to the anterior temple artery, for example. Yeah, you can reperfuse that. I mean, it will reperfuse. But if that flow is not enough, that flow won't help the motor cortex. So you can have a really nice MRI study, you can have a really nice perfusion test, you can have and everything in the temporal lobe, but the patient's still symptomatic, you know? The patient won't recover from the motor deficit. So that's also what Professor Shubin is doing. He's tailoring and targeting the bypass to the arteries that irrigate the cortex or which is the symptomatic for the patient.
Yeah, I think that's the selection of the recipient. It's very very important. And one thing I want to add is you can do bypass and then patient ended up without a stroke for the next 10 years. Then you realize your bypass is disappear. That means patient doesn't need the bypass. So that's also that's dangerous thing that we are doing something really invasive to the patient while the patient doesn't really need the bypass. So indication is very important. I always hold into Professor Charbel way of thinking that the physiological study must be very extensive because bypass is only a small percentage that contribute to the outcome. We have another panelist raising hand, Dr. Madi Gema from Bali. Dr. Madi Gema, please go ahead and unmute yourself.
Hello, thank you, Dr. Muhammad Kristiansyah. Hello, Dr. Degolado, Professor Degolado. I'm Dr. Gama from Bali.
Hi, nice to meet you.
Nice to meet you too. So in Bali, bypass is a new thing. There's no, but recently Dr. Muhammad Kristiansyah helped us to do the bypass in Moya Moya patient. So I'm very grateful for the Dr. Muhammad Kristiansyah. So I want to ask, it's interesting if you can do a bypass also in acute stroke. Actually, in here, a lot of patients maybe came with infarct and total MC occlusion that has a very already above 10 hours, and so the thing that we can do is maybe connectomy decompression and maybe also some synagniosis from temporal muscle. And in your opinion, is synagniosis really helpful or nowadays still useful in stroke patient? And
Okay.
for the second question, what about the follow-up after the bypass surgery? I mean, how long after the surgery do you have to do a MRI or MRI angiography, or do you need to do the PCD routinely in the outpatient clinic for the patient? And how about the anticoagulation, the drug? I mean the antiplatelet. How long do you give the patient for the drugs or any other medication do you give to the patient? Okay, thank you.
Okay, yeah, well, for the first question, I mean, bypass has a role in the acute stroke? Yes. Yeah. Or I mean, if you want an answer, yes. The thing is that most countries, and we know it, the first line of therapy is endovascular thrombectomy, yeah, mechanical thrombectomy. But the problem is that, like in Mexico or other countries, we don't have endovascular therapy because it's expensive of things, or they don't have angiosuite, or they don't have the right catheters or the stents and everything. So in patients that are or that have the same criteria for a mechanical thrombectomy are patients that are candidates to first to a surgical thrombectomy, as there are a lot of reports and everything that if you can detect an occlusion of the M1 segment and you don't have endovascular therapy and the patient is in a well window of treatment, you can enter that patient, open up the MCA, take out the thrombus, and repair it. I mean, that's a surgery that it's even, well, it's way less complicated than a bypass. Why? Because it's a normal pterional craniotomy that we're well familiar with that. It's just opening the sylvian fissure and putting a proximal clip, cutting up the artery, taking out the thrombus, and the arteriotomy will take only 3 to 4 stitches. So that's a one way to do it. But what we do in here is that patients that fail to have a good perfusion or a TC2 or TC3 post mechanical thrombectomy, they go to surgery, to the surgical thrombectomy. And if we don't see a good flow through the arteries, what we do is the bypass. But in this case, the important thing that we need to remember that in here is that if we don't know how long the stroke it has been going and everything, we can do as we discussed early in the lecture, we can do a high flow because of the risk of reperfusion bleeding. So we can do a single barrel, double barrel, or a minimax bypass. The important thing here is that when we do this bypass, the goal is not to reestablish all the blood flow to the cerebral cortex or the cerebral. We need to change the patient from penumbra to oligoemia. So if we change that, the principle or the great difference between those states is that if the patient is with penumbra, it's a symptomatic patient. A patient with oligoemia is not symptomatic. So if we do a bypass like this, we can hold the patient in that and we can give chance to the bypass so it can grow larger. And because it would be the difference of pressure and the pressure gradient. So in this case, we can use like that. So even in Tenshinkai, that they have all the equipment, the angio suites, all the catheters, all the stents, there are patients that they can reperfuse through the endovascular therapy. So the protocol in there is that patient, after the mechanical thrombectomy, if it fails, it goes directly to the OR to a bypass. So yeah, there's a role of bypass surgery. Yeah, I mean, it will be like we talk about it like it will be the third line of treatment. The first one is intravenous thrombolysis. The second one is mechanical thrombectomy. Third one is surgical treatment, that it's bypass or surgical thrombectomy. So there is a role. And the important thing is that the criteria are the same. And well, that's for answering the first question. The second one is that what do I do and what's the treatment for the patients after the bypass surgery, and what do I do or for how long I use aspirin? As I showed you, there are a lot of studies that they show that at 180 days, so 6 months, the wall shear stress in that bypass will be as similar as the rest of the body. So in that moment, the endothelium will be all around that bypass, and the pressure and the gradient will be already established. So that flow will be like a controlled flow or a auto-regulated flow by the body. So we use only aspirin for those 6 months to help the patient, and we don't use anticoagulation, and we only use aspirin. And the other thing is that what is the protocol after the surgery? Here, we use the protocol immediately after surgery. We use an angio-CT just to see the perfusion through the graft and everything, and we use transcranial Doppler to measure the flows and velocity through the arteries in the early post-op. And the first, the first perfusion test, we do it to the first week, and after that 3 months, and then 6 months to see how it changes. But that's it. After that, we don't use usually an angiography or a digital subtraction, everything for just to check that the bypass is flowing. I mean, with a normal angio-CT, you can see that. So, and you can check the flow and the velocity with the Doppler. So we don't use that because, I mean, it's invasive, it's everything. So we try to only do that. And the perfusion test, we do it at the first week and then 3 months later to see how the patient is going. And after that, 6 months. And if the 6 months perfusion test and everything is okay, we have covered the 6 months with aspirin, and after that we suspend it so the patient can go on like that.
Okay, thank you, Professor. How about the EDAMS or synaesthesis from the temporal muscles?
Okay.
What
Yeah,
is your
for the
opinion?
synaesthesis for stroke, I mean, we have to remember that even if we do the synaesthesis of any kind, muscle, dura, MMA, or anything, it will not give enough flow directly to the brain. And in an acute state of stroke, we need flow. So I think that in the acute state, it's a good way. It's not a good way. But in the chronic state, in the chronic phase, if you're not able to do a bypass and you can do this to help the patient, I'm pretty sure that the flow will get better. How much? That's the problem. We can measure how much flow is going to go through that EDAS or MDAS or any kind of indirect revascularization that we use. I think that's the problem. But I mean, if you can do bypass but you can offer the patient this, yeah, I'm pretty sure that perfusion will get better.
Okay, thank you, Professor. I hope we can discuss more about this bypass because in our center recently we just built a new code stroke system, so we find an increasing we find a lot more patient with chronic carotid occlusion. So I think bypass has to be done, but I don't know. The indication has to be strict, I think.
Yeah, I mean,
Thank you, Professor.
it's pretty strict, but I mean, that's the reason why in select patients and well-select patients, bypass is really helpful. As Mohammed said, like if we try to do bypass for a lot of patients will fail. So the important thing is to know the indication for the patient.
Yeah, thank you, Professor. Thank you, Dr. Chris.
Thank you, Dr. Gema. So that's an interesting point about. I hope you still. It's been 2 hours. I hope it's okay. That
Yeah,
I
don't
didn't
worry.
expect the discussion to be very, very interesting. And about the question from Dr. Gema, I think we should. His comment about this also, Dr. Shannon. I think you should reserve indirect anastomosis for moya moya because it's a totally different game, and it's all about predictability. You have to predict the patency of your flow. You have to predict how long you can establish equilibrium in the brain. And it's I like the term by Professor Fadi Charbel. It's an arm race between ischemia and reperfusion by your bypass. So we cannot wait. We cannot wait for the synangiosis to happen because it's not happened during after the surgery. Even after a few weeks after surgery, there's still no augmentation with indirect anastomosis. And it's all about timing, because when patient have repeated TIA, we can never know when the next TIA will happen, or even the next stroke, or the core of the stroke will increase and we lost the penumbra. So my you know my principle is we do only direct for atherosclerosis stroke. What do you think about that, Javier?
Yeah, as I told you, I think that there are not actually studies about studying in the indirect bypass for atherosclerosis because, as you told us, like I think that we vascular surgeons are pretty strict with what we do, and we always want things to be perfect and in our control. So we need to know how much flow do I need, how long is going to be that graft, how many stitches is going to make. I mean, we're pretty obsessive with those all those details. And as you told us, like even in Moya patients, after you do an indirect bypass, the bypass is not that indirect connection will not flow through the brain, as you told us. So it will take long. I mean, the studies show that it can be from 3 to 6 months that you can actually see how much flow is going to go through that EDAS or MDAS or everything to the brain. So those 3 months, as you said, we don't know if the patient will have a stroke in that time. And you will be punishing yourself for not doing a bypass and just waiting for that to give you the flow. I think that if you are trained and you are capable of doing bypass, you should do it. I mean, as Professor Krish told me, like it's important to know your limits, but don't have limits. What he means with this is that if you're not capable, I mean, you can call someone to help you, but you have to know that it's possible and know that your limit right now is here because you can do it. But nobody was born knowing doing bypass. I mean, to do bypass, you have to have discipline, obsession. You have to like it. You have to, as you told, be crazy about this kind of surgery. So you can train that hard to accomplish that. So I think that, as you said, the most important thing here is always the patient and not our ego or I mean, I don't know in all places, but at least here in Mexico, that's one problem. Sometimes other surgeons don't want to ask for help because they think, oh, why I will ask help for someone else? So I think the most important thing is the patient, as you told us, that if the patient goes well, all the case is it's a good case. It doesn't matter who actually did the surgery, you know?
Yeah, totally agree. Uh, and probably, yeah, we already 2 hours, but I have one last thing to add, and this is very important, and I want to hear your comment about this as well. And this is very basic, but if we disregard this, it can be very dangerous. The principle of not trying to augment a dead brain. This is very simple. This is look trivial, but it can cause harm to the patient. And I s- the- I saw some debate about doing bypass in the acute phase and the timing after failed thrombectomy. The recent study in American Heart Association journal says good result, 55% good outcome. That's pretty high for acute bypass in stroke in LVO. And uh, you know, the timing quite varies. Some people do it under 6 hours, and some people even do it after 72 hours. Within 3 days, they do it, and they still have a good outcome. But I think the main problem of the debate is whether there's a penumbra to save, because if if the if there is no mismatch and you do it under 6 hours, regardless the timing, you will injure the brain and cause hemorrhage. And this also applies to the selection of the graft. And I have some cases about this problem in atherosclerosis and moyamoya patient. Some of the cortical brain is already dead, and then when you want to do bypass, you really have to avoid that part of the brain. I even sometimes kills if I do a bypass to the M4 MCA and some branch of the M4 MCA goes into that part of the brain, I will kill those arteries because I'm really afraid of the postoperative hemorrhage. Please, what is your comment about?
Yeah, I mean, the important thing here is, as I told you, and I think I was pretty clear about it, is to study well the patient. So if you know that part has a stroke, for example, this patient that I presented, it had a previous stroke. So I knew that I didn't have to go and send flow to there because, as you will say, that will harm the brain, that will harm the anastomosis, and that will impact directly in the outcome of the patient. So it's really important, yes, to study the patient and understand that it's not the same case a patient that has been with a stroke with 2 hours, 6 hours, 18 hours, 24 hours. I mean, even with extended protocols with perfusion and everything, we know that if the patient has had happened in the stroke for a longer time, the outcome will be worse. So, and it's a completely different animal, the acute phase of the stroke and the chronic phase. So the indications are different, the strategies are different, what you aiming is different. As you told us, like if that brain blood barrier is disrupted, the patient will have a reperfusion bleeding. So that's why the autoregulating bypass enters, and that's why in the acute state that has been longer than 6 hours and everything, most people and all the studies point to STA because that's the point. You have to save the penumbra part or the penumbra part of the brain, but you don't have to take it to normal blood flow. You just have to change it from penumbra to oligoemia. That's the goal of the bypass. We don't have to reestablish all blood flow with a perfect the perfusion test. We just have to shift that. And shifting that will allow and will help the patient and will allow the body to compensate that flow. Because if we do this, we can help the ACOM to open, we can help the PCOM to open and everything. So the brain will start managing things, so you are helping it, but you don't have, so that's why I think there are like completely different pathologies and we have to study it differently. And the goals that we need to aim for an acute and a chronic state are completely different. So that's the thing. You have only to do a flow replacement, flow augmentation, the indication of the bypass.
Yeah, so thank you very much. And yeah, it's way more than the allowed time. We're already more than 1.5 hours because the allowed time by the Ministry of Health for the CMA point is 1.5 hours, but we are doing 2 hour, almost 2.5 hours. But yeah, and some of the panelists already leave because they have to do surgery and do to the clinic. But this is really an amazing discussion. I really thank you for this opportunity. And for all the participants, don't forget to fill the link, to click the link of the CME, the LMS, and absensi. Tolong diklik absensinya untuk mendapatkan sertifikat. So thank you very much, Dr. Javier, and I hope to see you again. I'm sorry, I think yeah, Dr. Aber just joined us again. He's my head of department, and probably Dr. Aber, you want to say some comment before we are closing our webinar.
Hi, Brother Gacha. Sorry, I'm in the middle. I'm in the middle of the street. I'm going to the next city around 2 hours, 3 hours from Jakarta. There is a giant paraclinoid aneurysms, but I will doing the flow diverter, not a high flow bypass. But thank you for your kindness and very fruitful discussions. And Coach Dians are doing a really amazing job in our hospitals. He's starting a great job, and I think uh, we have a lot of homework how to popularize again the bypass in our country. And I really hope that you can uh, always support Coach Diansa and shout at him also if he's doing bad things. And thank you so much. Really thankful to have you in this discussion.
No, thank you. Thank you so much for having me. I will always help Mohammed. I mean, we're like battle buddies or battle brothers in this. As you say, we need to reteach the people and reteach the world that bypass surgery is not dead, but it just has to be done in the perfect way, in a proper way. So thank you so much for having me. I will be happy to help you anytime you need. It was nice meeting you.
Thank you.
Thank you.
Yeah, thank you. We are an alliance of crazy people. So yeah, so thank you for all the participants, and Dr. Javier, thank you. We will be having another session like this next time, probably next week. Yeah, in the weekend of next week, we're gonna talk about thrombectomy. And if you have time, we will be happy to have you as one of the panelists. So we can have a nice discussion. So
Yeah.
thank you very much for all the
That's great.
panelists. Thank you for your panelists and participants. We will be seeing you again soon in the webinar series of the World Stroke Day. So we will have several webinars until the end of this month. Please keep in touch with our social media and do not hesitate to contact us if you need any information about our programs. So I'll see you again. See you, Javier. See you again. Bye.
Yeah. Thank you so much, Mohammed. You know, you can count on me always.
Thank you. Yeah, host, you can end the webinar. Thank you.
Okay, Kus, thank you.
I think we lost Mohammed, right?
Thank you, Professor De Garcia, for the discussion.
No, thank you.
Okay, bye.
Bye.